Welcome to lung ultrasound for COVID-19. This is Chelsea Walker Tagawa. I work at Triplet Army Medical Center, and I'm really lucky to work with the family medicine residency. I do family medicine and sports medicine. I am the primary care sports medicine director. So let's talk why we're using ultrasound for COVID-19. Specifically with COVID, we are seeing a lot of lung abnormalities that develop before even clinical manifestations and symptoms. So some people are having lung changes even before the nucleic acid detection. And early CT screening was initially recommended for suspected patients, but CT scans are limited because of how contagious this disease is. There's a huge risk in transporting unstable patients, people who are unstable, who are hypoxemic, who have hypodynamic failure. Just transportation into the CT scan is a big deal. And then also once you get to the CT scanner, that CT scanner is down for hours as it has to be decontaminated between patients for COVID positive patients. Ultrasound gives results that are similar to chest CT, and per the studies, they're actually showing it's superior to chest x-ray for the evaluation of pneumonia and ARDS. There's the added advantage for point of care use, so bedside ultrasound use, which we use a lot here in family medicine on a daily basis. It's easily repeatable, and there's the absence of radiation exposure, there's the low cost. It also reduces healthcare workers' risk of exposure. It's pretty easy to put a portable ultrasound into a sleeve and completely protect the patient as well as the practitioner. So ultrasound findings, you'll typically find imaging. Usually you'll see on like chest x-ray, pulmonary ground glass, consolidations, opacities, and lesions. They're usually peripherally located, and they're usually bilateral, and they favor the lower lungs. So specifically on ultrasound, what you'll see is focal B lines, fused B lines. You'll actually see the pleural be discontinuous, and it has this rough, jagged appearance, and subpleural consolidations as well. Foci of disease are usually in the posterior lung field, so specifically in the lower lung fields, bilaterally, kind of in the back. And so this is a picture from Butterfly IQ, and basically it shows these boxes show pleural line irregularities. So you see how this is kind of a straighter pleural line, but you see this irregularity here. The white arrows actually shows you vertical artifacts that are irregular, and the arrowhead shows your consolidations, so below here. This again is the pleural irregularities. So again, this is a nice straight pleural here, and this is how you can see it's kind of a irregular, jagged type of pleura in here and here. And again, the thick, irregular vertical artifacts, as well as the subpleural consolidations right here. And here in this red spot, you'll see areas of white lung. This is the red arrow. So again, what you'll see on CT scan is a thickened pleura. You'll see that ground glass appearance, effusions. You'll see pulmonary infiltrative shadowing, subpleural consolidation, translobar consolidation, and pleural effusion is very rare, and usually more than 2 lobes are affected. In the super early stage, you'll actually see negative or abnormal atypical lung findings, but you'll see diffuse scattered or ground glass shadow as it progresses with further lung consolidation. On the ultrasound, what you're looking for is B lines. They're usually multifocal. They can be discrete or confluent. You'll see these little consolidations, so centrometric consolidations. You can see them non-translobar and translobar. Pleural effusions are still rare, even under ultrasound. And again, you'll have more than one lobe affected. So in early stage and early disease, you'll see focal B lines, and you'll have alveolar interstitial syndrome as it progresses, especially in a critically ill patient. A lines can be found as the patient is healing, and then pleural line thickening with uneven B lines can be seen in patients with pulmonary fibrosis.
This is a lung ultrasound. We are in a lung
Here's a
preset.
video.
We
This
have
shows
rib
us
and
the
shadow,
lung sliding.
adjacent
So
rib
this is
here
a
and
normal
shadow,
lung. You'll see
nice
lung sliding and A lines.
pleural line with nice
And this is
continuity,
from
left
the
and right
Butterfly
sliding,
Network
indicating the
COVID
absence of a
patient
pneumothorax at this level.
training.
And we see regularly spaced hyperechoic bright horizontal lines, which are A lines. These indicate reverberation artifact from a normal air-filled. This is an ultrasound study using the lung preset where we see rib and shadow, rib and shadow. The pleural line has been obscured by the development of a subpleural consolidation with air bronchograms visible within this subpleural consolidation, representative of a focal pneumonia in a patient with confirmed COVID-19 infection. This is a lung ultrasound study in a patient with confirmed COVID-19 infection. We're in a lung
finding
preset.
again.
We see a
You'll see
rib
the
here with the
thickened,
shadow,
irregular pleural
adjacent rib here.
line, the
This is the pleural
thickening,
line,
and the
and
B
we can see that
lines.
it's thickened and irregular. There are B lines, confluent B lines here, isolated B line emerging under this interspace, and some pleural thickening at the affected areas with some adjacent normal pleura and A lines. This is a lung ultrasound in a patient with confirmed COVID-19 infection. We are in a lung
irregular
preset.
pleural
We have
line,
rib and
and then
shadow,
also a small
rib here
subpleural
and
consolidation.
shadowing. This is the pleural line, and we can see scattered B lines emerging from the pleural line as vertical hyperechoic artifacts, as well as a thickened and somewhat irregular pleural line with small subpleural consolidations. This is a lung ultrasound study in a patient with confirmed COVID-19 infection.
Skip lesion.
We are in a
You'll
lung
see the
preset,
pleural
and we see
thickening,
rib here with
very
shadowing,
irregular
and
with a
adjacent rib here
discontinuity,
with
and
shadowing.
then the skip
This is the
lesion,
pleural
the B
line,
line with a skip
and you'll
lesion.
notice that there is some isolated B lines here as well as B lines there. During the sliding, you can see that there's thickening and irregularity of the pleural line with some discontinuity of the pleural line right there. And this pattern of thickened irregular pleura with scattered B lines and skip lesions where you have no B lines in this space between the two B lines is a characteristic finding that is emerging with COVID-19 infected patients. COVID-19 infected patients.
So where are we going to scan the lungs? So our hospital has developed a algorithm where we're going to do 12 different spots. So 4 in the front. 14 different spots. 4 in the front. So 2 upper, 2 lower, 6 in the back. 2, 3, 4, 5, 6. And what you want to remember is especially these lower 2 or lower 4, I should say, will probably be where it will be positive first, because again, COVID-19 seems to favor providing damage in the lower lobes in the posterior aspect. And then of course 2 in the axilla, so 2 spots in each side of the axilla. So there is a triage Summary, and this is from Dr. Mike Stone, also from the Butterfly Ultrasound. So really what we have developed is said patient's going to present. So we have our COVID tents here. They're going to present with symptoms typical for COVID, including cough, fever, fatigue, dyspnea. If they have a known COVID contact, if they went to a high area, or if they're a health provider who has a lot of contact with COVID, then we're going to do the initial diagnostic. So we're going to do a rapid flu and RSV, what we do here, and a COVID-19 PCR, check a pulse ox. And then here in our decision tree, we're going to do our POCUS lung ultrasound. So point of care ultrasound at the. Now, if there's no findings and no oxygen required, so that means a normal lung exam, the pleural looks good, and there's A lines are present, then you recommend that the patient stay home and then self-quarantine. If we do see changes, so B lines, but the patient does not need oxygen, so it's an abnormal ultrasound, but the oxygen is not necessary at this time. What we need for that patient is stay at home, self-quarantine, but we should definitely be following up on those patients to make sure that we monitor them if their disease should progress. The third possibility is that they do need some oxygen and they do have B lines. Definitely for this patient, any oxygen requirement means that they're getting admitted. We're going to do other viral testing. So for us, we do a biofire and daily lung ultrasound exams, and we do dedicated POCUS lung ultrasounds during the hospital stay. So this person is going to get watched very closely. Now, if they have oxygen required and we see consolidations in ultrasound, not only are we going to admit and do the viral testing and the daily ultrasound exams, this patient may actually already go to the ICU just for closer monitoring, and then continued monitoring with a point of care ultrasound throughout the patient's stay. But this person, because they already have consolidations, we're worried about their needing higher ventilation, needing things like actual intubation. So the impact of this is that lung ultrasound gives results similar to a chest CT. It can be used for the evaluation of pneumonia with the advantage of ease of use at point of care. It's very repeatable. There's no radiation. There's a minimal footprint, and it's a low cost. So similar findings can be found on a chest CT, increase the PCR test sensitivity. So this plus a PCR test increased the sensitivity of finding abnormalities to 98% versus just 60 something to 70% with just the swab at diagnosing COVID. So for us, it allows our troops to maintain readiness and adequate allocation of limited resources. So these are the references. This is an old ultrasound, just very quick review. So people who don't do a lot of lung ultrasound, this may be some important points. A lot about A lines, B lines, and then there's also this thing called Z lines. Let's talk about these. So A line is this horizontal line. It's an artifact and it indicates normal lung function and surface. So you see these lines here and here. So the A lines go this way, and that's normal and that's healthy. That means B lines are these vertical lines that go up and down, kind of look like comet tails, and they indicate subpleural interstitial edema. And if you have 3 or more per a space, that is abnormal. Again, 3 or more per any space, any rib space between 2 ribs is abnormal. A Z line is also known as a false B line. So it's like a reverberation artifact. It usually arises from the pleural line, and it can be normal. So these lines that go through here, so they don't have a really big flashlight-like appearance.